Right, welcome to this morning's lecture. My name is Paul Conroy. I'll be giving you a lecture, and then we're going to have a coffee break, and then Simon's going to stand up and talk to you. What we'll do is at the end of both lectures, we'll both get up and do questions and answers. So if you don't have any questions, just leave them right to the end of the laminitis section, and then we'll deal with it at the end. Okay, today's lecture, as you can see, is on biomechanical considerations and farrier treatment for laminitis. I'm not going to do sort of chapter and verse on laminitis today, definition, anatomy and so on. We're going to come at it from a slightly different angle and hopefully change the way that you think, or make you think about laminitis. Okay, what is biomechanics? Biomechanics is the branch of science that deals with forces acting upon and within a biological structure. Well, what does that mean? It means, well, exactly what it says really. Everything that's living, from us to animals to trees, leaves on trees, are all subjected to forces. And that's basically what biomechanics means. And then the second part is the effect that these forces have upon the structure that we're talking about. Okay, another word that you may have hopefully come across is a foot or a hoof mechanism, which means a foot or hoof mechanism is when the individual anatomical structures are working in harmony for the good of the whole. And here we see, hopefully you've all got horses' feet like this on your rounds. You can see that we've got a good hoof mechanism. Look, the wall thickness is the same all the way around, the sole's nice and healthy, the frog's the normal shape, the heel's end just before the heel buttress. And that is a normal, well-formed foot. And everything that we do in farriery is aimed at trying to create this good, healthy foot. If you see a foot like this, or you have a foot like this, then generally speaking, all the individual anatomical structures are working in harmony for the good of the whole. Balance, another word that's used a lot. The definition of balance is a point at mid-stance where all the individual structures are loaded evenly. Okay, throw me now. Balance. There's many definitions of balance, but biomechanically, the point of it starts where all the individual structures are loaded evenly. Our problem starts as farriers that we see when all the individual anatomical structures are not loaded evenly, and one of them is taking more strain, which then collapses, which then snowballs into the feet that have all the problems. Okay, foot mechanics. When we're talking about biomechanics, we have to understand how the horse transfers its weight. For us as humans, it's really easy. Our heel bones are in direct contact with the ground. Alright, there's a thin layer of skin, but in general, the transfer of weight, our descending body weight meets the ground reaction force, and the gap is zero because our heels are on the ground. The horse isn't quite so lucky when it comes to that. If you think about the orientation of P3 in the foot, it's suspended completely off the ground, which means the whole horse's skeleton is suspended off the ground. Now the horse needs a way of transferring that weight and getting it down onto the ground. And it does this in quite a unique way, again using biomechanics. There's two main forces acting upon the foot when the horse lands, and they're tensile forces and compressive forces. On this picture here we've got the descending horse's body weight, which the force acting upon that is gravity. Gravity is a push force, another word, the pull of gravity. It's not technically true. So gravity pushes things downwards and it creates mass, which is the weight of the horse. So you've got your descending horse's body weight travelling down this way, and it meets the ground reaction force, which is an upward pushing force, which is the thing that stops us from just continually sinking down into the ground. These forces meet inside the foot, but as you know, because the bone is suspended, the horse can't transfer its weight directly downwards. Now it does do that using the anti-concussive mechanism. The digital cushion and so on helps with that, but it also needs a way of transferring its weight down to the ground, and it does this two ways. First of all, it utilises tensile forces, which on this diagram here are the yellow arrows. The tensile forces cross the laminal bed and enter the hoof wall, and the further out towards the hoof wall it gets, it starts to be influenced by compressive forces, which is a downward force. Now, horn tubules, if you think about the makeup of the hoof wall, the horn tubules are, as the name suggests, tubes. And if you've got like toilet roll tubes, kitchen roll tubes, and you take them together, you could actually stand on them and they wouldn't collapse because they are really high compressive strength, so they can withstand a lot of compressive forces. What they're not very good at doing is dealing with tensile forces, which are the cross forces. However, intertubular horn, which is the cemented stuff that goes around the horn tubules, is very, very good at withstanding tensile forces. So within the hoof, we have two structures that are very good at dealing with specific forces. So these tensile forces are more prevalent on the laminal bed as you travel out through the wall. Now, Professor John Riley did a study on horn tubular density, and he found that if you cut through the hoof, you have a higher concentration of intertubular horn on the inner surface of the hoof wall, and as you travel out towards the front of the dorsal wall, we have a much greater concentration of horn tubules, and that simply reflects the forces that are acting upon the foot. So the point in the hoof where the forces are tensile, we have a lot more intertubular horn, and as we travel out through the wall and we start to be influenced by the compressive force, we have a greater density of horn tubules. You can see this green line here is the direct compressive force. We have a force vector here, and this arrow here is a downward pressure down to the ground where it forms pressure. Pressure is simply, if you walk on sand, then you leave a footprint, and it's the force that leaves the footprint is pressure. So that basically speaking, you've got the descending body weight, you've got the upward ground reaction force, it transfers its weight across the laminal bed onto the dorsal wall, it then travels down the dorsal wall where it creates pressure. And that is how the horse effectively deals with the fact that its skeleton is not in direct contact with the ground, or is not anywhere near the ground. Okay, here is a magnified image of the hoof, and if you look at this area here, you can see we've got the insensitive laminae, and as we travel through the wall, you can see these little pits of the horn tubules, and you can see that as you travel out, they get much denser, so when you get close to the wall, there's a much greater concentration of tubular horn, and in this section here, there's a much greater concentration of intertubular horn. Okay, what happens during laminitis? It's exactly the same image. Obviously you can see that the horse has got quite severe rotation there. The thing I want to concentrate on is the yellow arrow. If you think back to the previous slide with the nice uniformed arrows that are crossing the laminal bed, you can see that once this bone starts to rotate, the downward pressure and the upward pressure remain exactly the same. The pull of the deep digital flexor tendon remains exactly the same. The horse can no longer effectively transfer the tensile forces across the laminal bed onto the wall and then down to the ground, which it has to do for the hoof to function correctly. And quite often you see in laminitis that the foot just tears itself apart, and the reason for this is this laminal wedge, which we're going to talk about later on. But it's just giving you a basic understanding of biomechanics and how this foot lands and loads, and hopefully give you a better understanding of what happens and why. You can see that these tensile forces are being pushed and pulled all over, and not nearly the amount of weight is being transferred across that way, which just adds to the problems. Once the laminae start to fail, thus we get rotation. This one's a venogram just showing the effects of laminitis. Not only, obviously you can see that the blood supply is severely compromised in this area here, but if you look at the limb as well, you can see that it's affected here. So it's not just a foot problem when it comes to laminitis, although as areas that's what we're pretty much left to deal with. Okay, so that's just a quick bit on biomechanics. I want to spend a bit longer now on the farrier retreatment side of life. The next one. Okay, I'm going to list some treatment considerations that you should hopefully bring into consideration and understand. The first one is know your anatomy. Obviously, it's impossible to effectively treat a horse with laminitis, and let's face it, laminitis is a killer. It kills a hell of a lot of horses every year. By knowing your anatomy, knowing the correct orientation of P3 and where everything should be in the foot, then it will certainly help you in your treatment of laminitis. Second one is to have a fundamental understanding of biomechanics. Everything that I've just said about how the foot lands and how the foot loads. If you can remember that first picture with the nice tensile forces and the compressive forces, and you can remember the picture with the healthy foot mechanism, then it gives you something to aim for in your treatment and trying to restore normal foot mechanics. Understand the progression of laminitis. Laminitis is an incredibly complicated disease, but your treatment as a farrier is very much dictated by where the horse is in the progression of laminitis. And if you apply the wrong shoe at the wrong time, or you do the wrong thing at the wrong time, then it can lead to other problems which, if you're honest, you've kind of created yourself. And once that starts to happen, you're then behind the disease and you're forever trying to chase it. If you can stay in front of it and notice the telltale signs, then life becomes a lot easier. We've done it. Different stages require different approaches, as it will become clear as we go through each stage of the disease. It's not a case of just slapping a hard bar on the end of a horse's foot without paying any consideration to where we are in the disease. Okay, when it comes to treating laminitis, like I said before, we all know where we are with laminitis, and we all know where we want to get to. Quite often it's the bit in the middle, how to get there, that is a little bit hazy and a little bit difficult to understand sometimes. So it certainly helps if you ask yourself two fundamental questions before you start on your farrier treatment for laminitis. The first one is, what structures are capable of bearing weight? It's not a case with laminitis that you've just simply got a bone that's rotated and everything else in the foot is functioning normally. As you no doubt know, it isn't the case. You end up coming across various other problems, and there's no point putting a shoe or putting pressure in places that you don't want to be putting pressure. Laminitis is all about pressure really, and it's what you do with that pressure and where you put the shoe and apply that pressure in the correct place. The second question is, what type of shoe can be used to accommodate the available sound areas of the hoof? Again, things like solar depth. If you're struggling with solar depth and you start putting shoes across the sole, then you're going to compromise the sole even further. So it's understanding which areas can and can't be used. And it may be a question of, you know that further down the line you have to do something with regards to the laminal wedge, but at the moment, if the horse is having acute laminitis, you can't afford to try and do everything in one shoeing. Sometimes you have to offset some of your treatment to further down the line for the sake of maintaining the horse's ability to bear weight, because once you lose that, it doesn't really matter what shoe you put on the end of the feet. The end result is going to be the same, which is euthanasia. Okay, so if you just think about the shoes before you put them on, and you ask yourself then two questions. It's in the handout as well, wherever it is. Okay, let's just quickly go through the classifications of laminitis, and then we'll go back and we'll talk about each particular one. The first one is developmental. Now, some vets, I was speaking to Simon about it the other day, some vets don't believe that this stage exists at all. They class developmental as acute as well. And all developmental means is it's when the disease starts to happen, the building blocks are in place to trigger laminitis. As soon as we start to see the signs of laminitis and we start to get the lameness and so on, then we quickly move on to acute laminitis. Acute laminitis is the blood supply has been compromised, the lamina is starting to become inflamed, the pain, you start to get the pain, the laminitic stance, everything you'd expect to see, increased digital pulse, etc., etc. Right up to the point before the bone starts to rotate is classed as acute laminitis. The second the bone does start to rotate, then we move on to acute founder. On to the next one. After acute founder, when the bone's rotated, a lot of the time the bone then starts to stabilise and starts to slow down. We move on to chronic founder type 1. Next one. The one after that, which I'll explain the difference between type 1 and type 2 later on. We move on to chronic founder type 2, and then finally, one that's kind of separate from the others is probably our worst nightmare, is the sinker. Okay, all grades of laminitis. This was written in 1948. Hopefully you'll all recognise these signs. Grade 1 features frequent shifting of weight between the feet, no discernible lameness at the walk, and bilateral lameness at the trot. Grade 2, horses do not resist having the foreleg lifted, nor are they reluctant to walk, but they do show lameness at the walk. Grade 2 quite often is the point where, as far as we get involved and we get called out, the horse will pick its foot up, it's not particularly comfortable, but it will do it. And then later on we start to get to the more serious ones. Horses do resist having the foreleg lifted and are reluctant to walk. I'm sure we've all had to do horses like this. And then the final one, horses will walk only if forced. So that was written in 1948 and it's still true today. Okay, developmental laminitis. As I explained when we went through laminitis, there are no signs. It's when the building blocks are in place, so as a result, there is no treatment for it. You will never get called out to a horse. A vet will never phone you up and say, I've got a horse with developmental laminitis. This stage, however, you will possibly get called out to. Okay, this is the early stages of the disease. Although it's quite painful, horses can have acute laminitis without moving on to acute founder. They kind of go to the edge of laminitis, and then if the cause is removed, especially fat pony laminitis, which is kind of the easiest one to treat once the cause is removed, compared to some of the equimetabolic syndrome Cushing's, which are far more complicated to treat. If the acute phase is left untreated, it will progress onto another stage. Quite often, if it is treated, it still will progress onto the next stage. Okay, conservative trimming. At this stage in laminitis, the horse is in severe pain. The last thing it wants is you coming out as a farrier and start doing really aggressive trimming on the horse's feet, simply because of what may happen in the future. If you aggressively start to trim the feet, all you're doing is you're making life harder for yourself down the line, and you're going to create more problems. I put up preserved solar depth. For me personally, solar depth is the number one consideration when treating a laminitic horse. When you look at an X-ray, it's certainly the first thing that I look at is solar depth, and that goes back to conservative trimming. If you start stripping the soles right out and you aggressively dress back the wall, then you're effectively, again, think back to that diagram of how the horse transfers its weight. If you're aggressive at this stage of the disease, you're effectively giving the horse no chance of transferring its weight. If the horse can't transfer its weight effectively onto its wall and down to the ground, then you're putting weight on other structures and you start to lose the foot mechanism. Once you start to lose that, the whole foot starts to change and things start to happen incredibly fast, and again, you're behind the disease. Bear in mind that things will change over the coming months. All that means is the foot that you're looking at the moment, if you've got a horse with acute laminitis, you can be pretty much certain that the next time you come back to trim it, things will have changed inside the foot and things will start to change from what you can see in the hoof. Quite often in the acute phase, the foot will look normal because we have no bone movement. Another big one in the acute stage of laminitis is avoid using the sole to build weight at this stage. What I would say to you is if you have got to put a heart bar on, hopefully it won't be a steel one, it'll be an imprint or a glue-on shoe, is just leave a tiny little bit of wall at the toe and ensure that when you put the shoe on, the actual shoe itself is sitting on the wall and not pressing on the sole. And certainly don't fit the shoe across the sole, because as I've said to you up here, solar depth is really important. If you've got a foot that's failing and you start to apply upward pressure across the sole, all you'll do is restrict the blood supply to the sole and the papillae of the sole, and you start to lose solar depth. We continue on. Over-trimming the dorsal wall will result in a loss of integral strength. Now there's probably two types of farriers in here. One is the ones that believe in dumping the wall, and the ones that believe in aggressively dressing the wall back to keep the hoof passing axis in line. I would say to you that both of them are correct, as long as they're used at the correct stage of the disease. At this stage, I would say that dumping the wall is a far better way of treating the horse. Now yes, the laminar wedge is going to form later on when we start to deal with chronics, and I would suggest that at this stage of the disease, allow the laminar wedge to form, obviously not too great, but don't start trying to dress back aggressively the dorsal wall, because all you'll do is, if you think back to, again, the first slide of how the horse transfers its weight, once you go through them horn tubules at the front, the horse can no longer withstand the compressive force, and the compressive force is constant. And all you'll do is you'll start to overload structures that can't deal with it, and then the whole foot will start to collapse. So if you dump the wall back slightly, you're leaving the integrity of the dorsal wall and at least giving the foot a chance when the bone does start to rotate of being able to support itself. If the foot starts to rotate onto a sole that's very thin because you've aggressively dressed it back, hopefully you can see the problems that are starting to arise by I don't want to say incorrectly shoeing the horse, but not really giving thought for the stage of the disease that we're at. The problems that you get with chronic laminitics are the laminar wedge, and times like that, it is time to aggressively dress the dorsal wall back and start to realign everything. But at this stage, again, that top point there, just bear it in mind, and there is no right and wrong answer. You just have to decide yourself what you can and can't get away with. And again, if you keep that first slide in your mind, then it will help you in your decision making. Transferring the weight from the wall to the frog. We know in laminitis that the wall's failing, the lamina is failing, so we need to start to use other structures that are capable of bearing weight, and the frog is a good structure for that. The use of non-traumatic temporary frog support, which is the old roll-up bandage tape to the foot. I put that up there because quite often it takes a while to come out, measure the feet, get the heart bars, get whatever your treatment plan is, and also owners can do this as well. It's just, again, all we're doing is we're using the frog in a temporary manner. And if we are going to shoe at this stage, glue-on shoes are almost always preferred, simply because you turn up to somewhere that's got acute laminitis, she's certainly not going to let you, even sedated, she's not going to let you bolt steel hard bars on, and quite often the pressure's too much anyway. Okay, so at this stage of the disease, things like imprint shoes are really good. Okay, so we move on to the next one, acute founder. Everything that I've just talked about in the acute phase still applies, plus these are extra considerations when it comes to acute founder. What is acute founder? Well, the lamina is starting to fail. The bone moves distally in the hoof, crushing the circumflex artery. The lameness is severe. To be fair, the lameness is severe and acute as well. And a palpable depression develops at the dorsal region of the coronary band. Okay, clinical and radiographic evaluation will show the following. Loss of solar depth. I've already mentioned solar depth once already, and it comes up probably about 10 times. Solar depth, when we start to get acute founder, it's something that you need to keep your eye on, because again, like I said before, once you start to lose it, things start to happen quite quickly. Know your anatomy. The incorrect orientation of P3, if Mr. Vet puts an X-ray up and you don't know what P3 should look like in the first place, then how are you supposed to know exactly what you're dealing with? You'll nearly always see solar bruising around the peripheral edge of P3. The severity of that depends on the amount of rotation and where in the stage of the disease that you see in it. It can vary from quite a mild discoloration to serious bruising to you can actually see the bone sticking through the sole. You'll almost always see some degree of solar prolapse. This is where the chronic stages of the disease are starting to kick in, drop soles, and so on. This is a horse this is ongoing and current at the moment. It's a good example of what can happen with a catastrophic loss of solar depth. We went out to do it, took the shoes off, and the bone is just about in there. This is all soft and dead tissue. You see the attachment of the lamina is completely gone. The sole that's protecting it is completely gone. However, the back half of the foot does remain still quite strong due to the bars, and the sole is relatively healthy in this region. You can see in this region here, everything is completely and utterly totally destroyed. Now, there's a few problems with this foot and how to treat it. All I did was take the foot off, leave a little bit of dorsal wall, hoof wall proud, and then put a heart bar on this foot. Again, making sure that at no point was any of the metal, or it was metal in this case, is pressing onto the sole. You can see the effect of the loss of solar depth, and the last thing the horse needs is anything going across this region here. I knew that we'd already got severe detachment there. There's quite a big cavity, and I knew at some point a dorsal wall resection was going to be needed to restore the tensile forces, but at this particular moment that wasn't possible. If we were to resection the foot in this state now, with the sole the way it was, then the horse would have stood absolutely no chance. So we put the heart bar on, came back, it was just over 4 weeks later, and the only chance that the horse had really was that in that 4-week period, the solar depth was going to start to come back, and that's exactly what happened. You still see the trauma in some of the holes, but in general, there's a healthy sole growing underneath where this was. This is the same foot, it's only 4 or 5 weeks later. Once this starts to happen, then the treatment can change and you can deal with some of the other issues that the horse has got. But when we're in this stage here, you're kind of in survival mode, so just play it safe and make sure you sit the shoe on the wall, because that's still currently capable of bearing weight. The sole isn't. Solar prolapse is an example. I'm pretty sure you will have all seen this. You can clearly see here that the sole is prolapsing. Next one. It's a solar bruising around the peripheral edge of P3. Generally in laminitis you get two types of bruising. You get the bruising that you see around the white line, which in some cases can be quite wet and you get the serum. That's not too much of a concern. I don't tend to worry too much about bruising around the white line. It's the bruising that you see here is the one to really worry about. It's almost certainly a sign of rotation. In this particular horse, I mean, that bit there was P3, and that's pretty severe solar bruising. So this is the one to look out for, not so much the bruising around the white line. I'm sure it's a sign of laminitis, but quite often it's just the trauma of the actual disease itself and the death of the laminae that caused that. The peripheral edge bruising is bone movement. Okay, dorsal wall alignment of P3 weighed against the loss of hoof wall integrity. I covered that before with aggressively pressing back compared to dumping, and it's your call really, experience and so on, of just how much you want to take that. Glue on shoes, again at this stage the lameness is severe, the horse is in a lot of pain. Wherever possible, put the glue on shoes. That's not always the case, especially the really big horses. That last picture was a 6 1/4 inch foot, and he was a big horse with a lot of descending body weight. A lot of the time, getting glue on shoes to fit well on a foot that size is difficult, and also the stakes are so much higher for a heavier horse because the descending body weight is so much greater, and the forces inside the foot are so much greater. But if possible, and it's kind of on the horse, is glue on shoes. Pain management at this stage is crucial, which again comes down to your vet-farrier relationship, and obviously your vet will understand the importance of pain management. If the pain is really severe, some horses are quite strong and can withstand it, some horses just tend to give up. So if the vet can help to control the pain, then you'll be far more effective in your treatment. And for this one, lower the heels with caution, increased pain and hypertension. Again, we're in the acute phase of laminitis. The laminae have failed. They're continuing to fail because the inflammation is ongoing. The last thing we want to do is start whacking the heels down, as you would do on a chronic, to try and restore hip prostatitis and normal foot geometrics and so on. But at this stage in the disease, by lowering the heels, one, you'll increase the pain because you're going to increase the strain on the deep digital flexor tendon. You're going to increase the pull of the deep digital flexor tendon. And Newton's third law of motion, every action has an equal and opposite reaction. But in the healthy foot, the pull of the deep is equal to the bond of the laminae at the front. If one of them structures is failing, in this case the laminae, the deep digital flexor tendon will continue to pull at the same rate that it's always pulled. By you over-lowering the heels at this stage, what you're going to do is you're going to lower the deep even further. You're going to increase the pull on the deep onto failing laminae, and if anything, you'll increase rotation. You'll increase the strain on the tendon and you'll increase the pain, so you won't actually achieve anything at this stage of the disease. Okay, modern materials are fantastic, but again, think before using modern materials. If you are shoe analytic and you put your heart bar on and you want to support the back bit of the foot that little bit more, or you want to support the foot and you want to support the sole, then by all means use modern materials. The number one thing absolutely not to use is super fast in the sole, because you really will cripple it. You should never use super fast in the sole anyway, but if you start putting it in, because it's set so hard, it's very unforgiving on the horse, especially the horse with laminitis. And the second bit is you don't really want to be filling the front half of the foot. We just talked about solar prolapses and bruising and so on. If you fill the whole foot with sole pack, 9 times out of 10, you'll actually make it worse, because again, laminitis is all about pressure. You're putting an upward pressure exactly where the horse doesn't want it and doesn't need it. The back half of the foot needs supporting. So like in these photographs, fill the front half of the foot with Play-Doh and just fill the back half. Then when you take the Play-Doh out, the sole is nice and clear. If you... I forgot what I was going to say now. Yes, the front half of the foot is nice and clear. Okay, we're going to move on to chronic founder now, which is the bone. The foot is a little bit more stable, the bone has kind of stop rotating, and we start to see some of the chronic changes in the foot that again we have to deal with. For me personally, the acute phase is one type of treatment when you're dealing with a chronic, and the treatment does start to change slightly. If just one thing on the acute before we go on, if your farrier is good and effective at this stage, and you can offset a lot of the problems that you see with chronics in the acute phase, the worst thing as a farrier is to be called out to a horse that's chronic and all the problems are already there, and then you've got a lot of work to do to try and get it back. But if you think about what you're doing in the acute phase, you can offset a lot of the problems that we see in chronic laminitis. Okay, so initial radiographs will reveal no changes to P3. All that means, it doesn't mean that there's no changes in its orientation inside the foot, because as we know it's already rotated. What I mean by that is there are no changes to P3. If you were to look at it radiographically, P3 would be normal. It would be its normal shape, its normal size, just incorrectly positioned inside the hoof. An increased distance in laminar thickness, so the laminal wedge is starting to form, or is already formed. This is caused by inflammation of the laminal bed and hoof wall separation. As the hoof wall separates and the inflammation, as the tissues start to die, they haven't got anywhere to go. So they just build up and build up inside the hoof, which just increases rotation even further. Compression of the coronary corium between the extensor process and the coronary groove. As the bone rotates distally, the extensor process starts to compress the coronary corium, which is, as we know, this is where the hoof is produced. As it compresses downwards, it also compresses the circumflex artery and solar papillae, and this is where our problem starts with the loss of solar depth. The coronary corium and hoof wall producing structures are compromised. We all see it that you take the shoe off and there's absolutely no growth at all at the wall, and the heels are growing normally. Production of the wall at the toe is shut down. And then the growth gradually increases to normal towards the heels. A lot of people say that horses with laminitis grow more heel. It's not necessarily that they grow more heel, it's more the fact that they don't grow any toe, and the heel growth is normal. So when you pick up the foot, you have a ton of heel on and no toe. The new laminar attachment becomes difficult due to lack of growth at the toe. Now, again, think back to that first picture, the biomechanics one. What you're after with laminitis is, as the dorsal wall is growing down, the healthy one, you're after reattaching the laminae, the healthy laminae, and getting that good tensile force. It becomes really difficult once we start to get to the chronic founders, because hoof wall production has slowed right down or stopped, which makes this particularly difficult to restore. Okay, we have an inability of the remaining structures to bear weight, resulting in continued rotation, leading to chronic demineralization and chronic abscessation of P3. Abscessation of P3 is a difficult problem, especially when you've got glue-on shoes on. You put them on and then 2 days later it starts to develop an abscess and it's got to come off and it's got to be dug out and so on. Okay, here we have a classic chronic founder type 1 foot. You see the diverging growth rings at the toe down to the heels, which just reflects how slow the growth rate is at the front and how, not so much how quickly, how normally it is at the heels. If they're both growing at the same rate, you have nice horizontal growth rings. This way they're going down like this is a sure sign of laminitis. You can see that foot's looking quite chronic. If you used to pick it up, you'd have solar prolapse, drop soles and so on. Okay, now is the time in chronic founder is to start to restore this foot back to the way it should be. The foot in chronic founder is a lot more stable than it is in acute founder, so we can start to take a few more risks and be a little bit more aggressive in our trimming and chewing to try and restore it back to normal. Because as long as we keep this foot like this, with this big laminal wedge, you can clearly see the laminal wedge here, the foot will continue to turn itself apart and it won't be able to function correctly. So if we just leave this like this and close our mind off and just think we can put a heart band on the end of it, it's going to stay like this for the rest of its life. Okay, chronic founder type 2. I know that's a pretty severe example of chronic founder type 2. But the main difference, the main difference between chronic founder type 1 and chronic founder type 2 are via the x-rays. The one on the left is chronic founder type 1 and the one on the right is chronic founder type 2. Now, chronic founder type 1 and 2 has nothing to do with the degree of rotation. You can have a chronic founder type 1 that's prolapsed through the sole, and you can have a chronic founder type 2 that's only rotated slightly. The big thing is you can see the condition of P3. If P3 is normal, although it's out of line, then this is chronic fouler type 1. Once P3 starts to remodel and get compressed, sometimes you lose the peripheral edge of P3 all the way around. Then we start to move on to chronic fouler type 2. So radiographically speaking, the difference between the two are exactly what I've just said. However, there are other things that you would class as chronic fouler type 2 in. These horses tend to have a poor prognosis. Think back to the picture I just put up of chronic fouler type 2, the kind of ones that when you look at your heart sinks and you think, what am I going to do here with this? They often exhibit severe lameness, and that lameness remains constant through the whole time that you treat it. They don't tend to get any better. Distance of the P3 is often completely absorbed, in which case it's completely gone. Now that's another consideration when you look at the X-rays. The question you want to ask yourself is, are you looking at normal P3 or not? Because if you're trying to align the dorsal wall with P3, and P3 is effectively become a little cube, you're never going to achieve that. So a good thing is to ask the vet for a DP shot, about 60 degrees, where you can look down into the hoof and you can see the peripheral edge of P3. Quite often that's completely gone, especially in chronic fouler type 2 cases. If that's the case, then you're never really going to align the dorsal wall of the hoof with the parietal surface of P3. The horn tubules often grow at right angles to the limb. Again, the picture that I put up at the beginning is a good example when you get the really long toe. Continual bruising and abscessation. Contracted deep digital flexor tendons, and osteomyelitis, which is inflammation of the bone itself. Okay, so we've covered everything now. This next one is sinker, which kind of stands alone on its own, and like I said at the beginning, it's every farrier's worst nightmare. You really are up against it when you get sinkers. Okay, we have total destruction of the interlaminar bonding, and the bone is loose inside the hoof capsule. There's a palpable depression at the coronary band from heel to heel. In acute fouler, I'll put a picture up with you pressing the coronary band, you'll feel a depression there. In sinkers, you'll feel a depression all the way around from heel to heel. When you look at the radiographs of sinkers, quite often the orientation of P3 in the foot does look normal. That's because the whole bony column has sank inside the foot. And the way to test that is X-rays. Just go to the next one. Okay, this is where the importance of a correctly marked up X-rays. Is it fair on you as a farrier to be expected to come out and shoot even a horse with acute laminitis without adequately marked up X-rays? And that becomes even more important when you're dealing with horses with sinker. Because P3 may look normal inside the hoof, but it's actually sank, and the vet can do a measurement of fouler distance and so on. And the importance of the dorsal wall marker at the top, ending at the coronary band, at the most distal hair follicle, and the top of the coronary band, is really important because that's where you take a measurement from to see whether the bone sank inside the hoof. If that happens, then generally you're looking at a sinker, and at least although it's your worst nightmare, at least you do know what you're dealing with, rather than kind of looking at everything, oh, there's nothing wrong with that, it's not really got anything, but actually it's a sinker. Okay, on the X-rays as well, just the next one, is look for gas pockets or pockets of serum. Can you all see that line there, where the arrow's pointing to it? Horses with sinker, sometimes it's not a continuous line like that, you might just get a little tiny pocket of it, but it's definitely something to look out for on sinking horses. You can get them on horses that rotate as well, but generally it's on sinkers that you see this. This is really important if you do get it, and it has to be dealt with. Okay, with a sinker, if a gas pocket is present, a dorsal wall resection should be carried out. Again, speak to the vet and decide which type of dorsal wall resection you want to do, whether it be a full one, half one. Another option for you is dorsal wall ventilation, which is drilling like 3/8 of an inch hole into the hoof. If you've got good X-rays, then you can see where the gas pockets are. Then there's no need to do a full dorsal wall resection, because once you do that, you're removing the front bit of the hoof. Its ability to burn weight is reduced. So if you can get away with just dorsal wall ventilation by just drilling, then that's preferable. Quite often when you do get to the gas pocket, you'll either hear a hissing sound, or you'll get serum starts coming out of the foot, and a lot of the time the horse feels better instantly, because again, it's all about pressure, and that pressure's been relieved. Yeah, this allows the drainage of the hemorrhage and exudates. Please do not apply a heart bar if you have got a gas pocket, because what you'll do until you've released that pressure, if you apply a heart bar, again it's all about pressure, you're increasing the upward pressure. Now that pressure has to go somewhere, and it's trapped inside the hoof. So you will end up with a hydrostatic pressure blowout, which will just blow out the side of the hoof. So always bear this in mind when you've got a sinker, is just make doubly sure that there are no gas pockets or serum anywhere before you apply the hard bar shoe. Okay, non-traumatic front support shoes should always be preferred in sinker cases, which again is an imprint or a glue-on shoe. Okay, so they're the farrier treatment considerations that hopefully you should think about depending on where you are in the disease, and hopefully it highlights how the treatment can change depending on where we are. So I'm just going back to the chronics. I'm just going to quickly go back to the laminal wedge. The top one we can see the normal hoof. The bottom one we can see there's a bit of rotation. The orientation of the P3 in the foot itself isn't too bad, but we've got a big long dorsal wall, and this area here is the laminal wedge. Now, if this problem is not addressed, then as the laminae at the top, if you do manage to restore hoof production, as the laminae attach at the top, once it reaches this laminal wedge, all that will happen is it will just shear itself apart again, because as long as this little wedge of dead necrotic material remains, this will act as a lever and it will just separate the hoof. So once we start to move on to the chronic stage, this is where we can be a little bit more aggressive with our mask, dressing it back and trying to restore normal hoof mechanics. Now I do concede that if you do dress back aggressively at this stage, you are compromising the way that the horse can bear its weight. But at this stage, the foot is a lot more settled. Hopefully your solar depth is not a terrible concern. And now's the time to start asking other structures to bear some of the weight while you deal with the dorsal wall. Okay? Next one. So some considerations. Vascular dresses, dumping, I've talked about that already. Remember the tensile forces. Remember that first slide that I put up and the importance of restoring them nice, uniform tensile forces. And above all else, remember biomechanics. I put this up, do not ignore the laminal wedge. This is X-ray of as we've learned, it's a type 2 chronic founder. It's pretty much as bad as you can get. That bone is, the peripheral edge of that bone is completely gone. You can see here that P2 is pushing on the extensor process of P3, but more so, if you look at the alignment, we start to get this thing going on here, and then the distance is immense. On this one, you can see also the heels. I know I couldn't fit them both on, but the heels are long and the foot's really blocky and upright. The horse can't really function with the foot in this state, and you're never ever going to get it even comfortable, let alone not lame. The chances of getting the horse sound when you've got this going on in the foot is next to zero, but you can at least make him more comfortable. You see this one, this is after the laminal wedge is gone. This bone here, we took a DP shot on it and it completely worn away, so I'm never going to restore that level with that because the bone just isn't there anymore. You see this extensor process is almost gone as well. But at least the dorsal wall is starting to become aligned with the pasterns. Okay, you see that the laminal wedge that was here is starting to go, and if you think back again to that first slide, we're much more likely to restore the tensile forces and the compressive forces, and this foot is beginning to look normal-ish. So as far as I got it, but go on. As you probably can't see the top, it says capsular rotation versus phalangeal rotation. There are two types of rotation, and that is capsular and phalangeal. You can see, we'll deal with the phalangeal one first. You can see that P3 is rotating off its axis. Okay, these two bones are in line. This bone is not in line with the phalanges. Forget about the hoof orientation at this stage. This one, you can see that the phalanges are all in line. This P3 is not rotated off its axis. However, its orientation with the dorsal wall is out. This one on the left is capsular rotation, and this one on the right is phalangeal rotation. This one is by far the easiest to treat because a lot of it is just what you do with the hoof. This one is a little bit more difficult to treat. Some people call this true laminitis, and this one is not true laminitis, although they both are. So that's just capsular rotation and phalangeal rotation. Again, it's something to bear in mind when the vet puts the x-ray up and you're talking to the vet. It's something to look out for, so you know what you're dealing with. Okay, I'm just going to quickly go through hard bar shoes and some of the points of a hard bar shoe. It was derived from a design originally described in Dollar and Wheatley, 1898. So you can see it's a very old shoe. It has changed slightly over the years, but the principles of it remain the same. It is a precision shoe that must be fitted with extreme caution and used for the treatment of laminitis and founder. It's quite often just slapped on the end of a foot without any thought to the biomechanics that we've just talked about and how the foot lands and loads. And if you do apply a hard bar to a foot that is not where it needs to be, then it's never ever going to work. If anything, it's just going to create you more problems. It can cause further damage and rotation if fitted incorrectly. Okay, the heart piece must be fitted accurately to a point between the insertion of the deep digital flexor tendon and the terminal arch. Now, the insertion point of the deep digital flexor tendon is also known as the centre of pressure. I assume everyone's heard of Duckett's dot. Well, Duckett's dot is 3/8 of an inch back from the apex of the frog, and he says that if you draw a line up through Duckett's dot, that bisects the extensor process of P3, which is a point where the common digital extensor tendon inserts and the deep digital flexor tendon inserts underneath. That is the point in the foot where the pressure from those two tendons meet and equalise. So when it comes to fitting hard bars, if you measure 3/8 of an inch back from the apex of the trimmed frog and draw a line across your sole, when it comes to fit the hard bar, you put the hard bar on and it's in front of that line, then you kind of know that you're fitting your hard bar too long. Again, know your anatomy, know where the terminal arch is. It's not always easy to see on the radiograph, but you kind of know where it is, and the vet kind of knows where it is. But as long as you're behind the insertion point of the deep digital, then you're not going to create too many problems. The aim of fitting the hard bar shoe is to provide support beneath the dorsal half of the distal phalanx without compromising the blood supply. If the hard bar does not extend beyond the limits of the trimmed frog, the digital arterial supply will not be compromised. Okay? You may have been out to horses and someone's put a hard bar shoe on and it extends in front of the frog and it's really wide and the section of metal is not suitable for the foot. Then things start to happen. A lot of the time you put a hard bar on fitted incorrectly and you'll make the horse 10 times worse, which is quite worrying for the client because the horse is getting better. You put a hard bar on and suddenly they're 10 times worse. Quite often it's because, again, it's a pressure thing. You're putting pressure in the wrong place and the cost of that is the blood supply to the foot. Once we start to lose that, again, the cycle of laminitis then continues and we're back in trouble again. Anatomically unsympathetic fitting and application of the hard bar shoe will cause direct pressure, again leading to a compromise in the blood supply. I've put beware of the hard bar. That picture the hard bar itself wasn't incorrectly fitted. It's just if it is incorrectly fitted, we can have problems like that. You can see that the sole's completely failed all the way around, and the horse is lying down, which gives you a clue. Okay, I'm just going to quickly go on to AVA shunting, which stands for arterial venous anastomosis, and it's something that goes on in the foot, which is a real problem, and it's difficult to stop. Here we can see this is magnified 40 microns, I don't know. So here we have the artery, here we have the vein, and then we have this thing in the middle, which is the AVA. This contains tiny muscle fibres. Quite often it's closed in the healthy foot. Just go on. I'm just going to go through a series of diagrams which will hopefully help us understand it. So what we're dealing with is here's a primary laminae, we're into the secondary laminae here. So we're right down to minute levels. Here we have the artery, here we have the vein, we have the capillary beds where the exchange of oxygen and carbon dioxide takes place, and here we have the AVA, which is currently closed as it should be. Okay? The AVA is starting to open and some of the blood is getting diverted from the artery straight to the vein and then venal return back to the heart. Some of the blood is still making its way to the capillary beds, but they're starting to become inflamed, they're starting to become sore because the blood supply is starting to be reduced. Okay, we're moving on. The AVA is completely open now. All of the blood is being diverted through the AVA into the vein, back to the heart. The capillary beds are suffering, they're not receiving any blood. Finally, we have the start of laminitis, the build-up of the serum and the blood. You can see that these are starting to die off, the capillary beds, because they're not receiving any blood, which is the start of your laminal wedge. All this material here, and this is happening inside every one of them, inside the primary laminae. And here's a picture of sort of pulled out slightly. We have the arterial supply and the venous supply, these little white areas here in the area, so you can see there's quite a lot of them in each one. Okay, I'm just going to quickly go on about the vet-farrier relationship, because it is absolutely critical in any disease that you treat, but more so than ever in laminitis. The importance of a good and constructive relationship cannot be overstated. A strong relationship will greatly increase the horse's chance of surviving laminitis. Okay, if the farrier wishes to be treated with respect, then he or she must demonstrate a good understanding of the pathology of the disease, along with a good and sound method of treating the horse through proven and trusted protocols. All I mean by that is, if the vet comes out and asks you what you want, what you would rather do, and you say, oh, I'll put just make a shoe up, then he's not really going to take your opinion seriously, because you're obviously showing that you don't understand where you are in the disease, what's going on and so on. So the vet's more likely, especially the more experienced vets and the older vets, the more likely to completely discard what you're saying, and that's when the resentment starts to set in, that you're not being listened to, when really a lot of the time it's because he hasn't really got any confidence in that you know what you're doing. So a healthy debate is only possible through a relationship based on respect between the vet and the farrier. It must be remembered that the vet has the final say in the equine's treatment, and so will carry the can if all goes wrong. Therefore, he or she cannot be expected to treat the farrier's opinion seriously if they obviously cannot demonstrate a sound knowledge of the disease. Okay, that speaks for itself. That's exactly what I've just said. The vet, if everything goes wrong, then the vet's the one that's got to stand up and justify why he did what he did, not you. So by that, if you're saying you put an inside-out back-to-front shoe on, then of course he's going to completely ignore you, because he's the one that's responsible in charge of his care. It is also important for the attending vet, so I've had a go at farriers, I'm going to have a go at vets now. It's also important for the attending vet not to overlook the opinion and experience of a good and knowledgeable farrier. It's the farrier that will carry out the majority of the work, and as a result they have a wealth of experience in trimming and shoeing the laminitic horse. It's you guys that do the shoeing. You may have done, 20, 30 that year. You know what it feels like, you know what works and what doesn't work. The vet necessarily, especially fresh graduate vets, don't really understand the pathology of the disease, and they kind of rely on what they were taught at college and books and so on, which is quite often flawed. The last bit is important to remember that it's the welfare of the horse and not a person's ego that must come first. I'm sure we've all met vets that fit into this category. You may be right in what you're saying, but he's Mr. Vet and he's right at all costs. And then only a good and healthy relationship results in good lines of communication between the vet and farrier, where both are comfortable expressing opinions and reservations about various treatment possibilities. Now Simon's going to be standing up after me and giving me a talk. Simon, I have a good relationship with Simon, and he's quite a challenging vet, and he isn't frightened of giving his opinion, and I'll give my opinion. At the end of the day, if I give my opinion and he doesn't agree with it, and he wants me to put an inside-out back-to-front shoe on, then that's what I'll do. I'll tell him that I don't agree with it, and I think he's wrong, and he'll accept that, but he'll still say that he's right. And that's the kind of relationship you want with your vet. You're not at the point where you want to say something but you haven't got the confidence to, because he's a bit of a bully and he's a bit of a... Okay, if you know that you're right, then express your opinion. If he still wants to go down the route he wants to go down, then go down that route. Because if it all goes wrong, at least you've said your bit and you'll feel much better for it. But a good vet should always listen to you. And then probably the biggest, one of the most important ones is, if you haven't got anything to say, whether that be slagging each other off or having a go at each other, the last place to do it is through the horse's owner. Okay? If you have got a problem with the vet, and if the vet's got a problem with you, it's professional conduct to do that. It's laid down in the vet's code of conduct, as it's laid down in our code of conduct, is if you have a problem with a fellow professional, the first point of contact should be that professional and not the horse owner. If you start to say, or the vet starts to say, "I'll get your farrier to put this on," and she doesn't quite tell you correctly, or you misunderstand what she says, and she says, "Well, I can't remember what he said this." Okay, this is where critical information gets lost in translation and critical errors can be made. Once this starts to happen, the chances of the horse making a full recovery is reduced drastically. If this relationship is strong, then the horse stands a chance. Okay, that's the end of my bit.